Hello, this is Dr. Stanley Kim again. Currently, I'm working at Abbott Northwestern Hospital in Minneapolis, Minnesota, charming city in the Midwest. Today, we will discuss new development of lung cancer. Tremendous development and improvement were seen in field of lung cancer therapy. It's mostly due to new application of precision medicine with targeted therapy and the immunotherapy. They are used before surgery, after radiation therapy, or even after cancer spread to other organs. We'll discuss more in detail, and thank you for watching. New development and the changes are taking place for good in the field of lung cancer therapy since several years ago. The precision medicine with the immunotherapy and the targeted therapy is applied to every stages of lung cancer nowadays. For example, brain metastasis may be treated with a targeted therapy without surgery or radiation therapy, and the early lung cancer can be resected with a less traumatic surgery. With all these changes, the prognosis of lung cancer is improving. Let's review the anatomy of the lung quickly. Right lung has upper, mid, and the lower lobe. Left lung has upper and the lower lobe. Lingular segments belong to the upper lobe of the left lung. And there are mediastinal lymph nodes, station 2, 3, 4, 5, 6, 7, 8, 9. And the station 10 are hilar lymph nodes. WHO published a new classification of lung cancer in 2021. It uses immunohistochemistry throughout the classification and emphasizes genetic studies and provides small sample and the cytology classification in detail. And the new entity include SMARCA4 deficient undifferentiated tumor. Adenocarcinoma is the most common type of lung cancer, accounting for 50% of all. And the characteristics of immunohistochemical study of this adenocarcinoma are TTF1 positive, Nepsin A1 positive or negative, CK7 positive, and the P40 negative. This new classification restricted the diagnosis of large cell carcinoma only to resected tumors that lack any clear morphological or immunohistochemical differentiation, and reclassified remaining former large cell carcinoma subtypes into different categories like adenocarcinoma. Squamous cell carcinoma is the second most common, accounting for 30% of all. The characteristic is P40 positive, TTF1 negative, and the CK56 positive. The CK56 positive is also seen in mesothelioma. Squamous cell carcinoma was reclassified into keratinizing, non-keratinizing, and the basaloid subtype. Neuroendocrine tumor of the lung has positive chromogranin, synaptophytin, or CD56. The most common and the most aggressive neuroendocrine tumor of the lung is a small cell lung carcinoma, accounting for 15% of all. Characteristically, it has TTF positive, but other metastatic neuroendocrine tumor to the lung are negative for TTF1. Other invasive neuroendocrine tumors include large cell or small cell neuroendocrine carcinoma. The well-differentiated neuroendocrine tumor of the lung, which is also called carcinoid tumor, has two different types, typical and atypical, depending on the mitosis activity. If the mitosis number is less than 2 per 2 millimeters square, it's typical, which has better prognosis. But if the mitosis is over 2 to 10 or there is a necrosis, it's called atypical neuroendocrine carcinoid tumor. Sarcomatoid carcinoma is rare, has several different subtypes, pleomorphic, spindle cell, giant cell carcinoma, and the carcinosarcoma and blastoma. They are not responsive to chemotherapy. About 5% of small cell lung cancer are combined with the adenocarcinoma and the squamous cell carcinoma, and we call it combined squamous cell lung cancer. It's treated as a small cell lung cancer. Now, I'd like to explain how pathologists would subclassify the adenocarcinoma, the most common types of lung cancer, according to the new classification. First, look for lipidic pattern. Lipidic pattern means cancer cells grow in alveoli in the alveolar septum, not infiltrating into lymphovascular tissues. If predominantly lipidic pattern, then you look for invasiveness. If there is no invasion, adenocarcinoma in situ. If there is a microinvasion, 5 mm or less, it's called a microinvasive adenocarcinoma. If more than 5 mm, it's a lipidic adenocarcinoma. If there is no lipidic pattern, then you look for histologic patterns such as solid, papillary, micropapillary, and the acinar. Among these, solid and the papillary patterns are more aggressive, and the patients may need to have adjuvant chemotherapy. But micropapillary and the acinar patterns are less aggressive and the better prognosis. If there is no typical patterns, then it's a variant adenocarcinoma, including invasive mucinous adenocarcinoma, colloid adenocarcinoma, fetal adenocarcinoma, and the enteric adenocarcinoma. Briefly going over the staging of lung cancer according to the 8th edition, which I believe is published in 2017. T1 tumor is tumor up to 3 cm, T2 3 to 5 cm, T3 5 to 7 cm, T4 bigger than 7 cm. I like to emphasize that T2A tumor is bigger than 3 cm up to 4 cm because many clinical trials included a T2A, especially 4 cm tumor in their adjuvant treatment setting, adjuvant chemo immunotherapy. And the stage 1A means the tumor up to 3 cm without lymph node metastasis. Stage 1B, tumor up to 4 cm without lymph node metastasis. Stage 2A, T2 tumor without lymph node metastasis. Stage 2B, hilar lymph nodes with a T2 tumors, or T3 tumor without lymph node metastasis. Stage 3A is commonly seen, commonly T3 or 4 with a hilar lymph node metastasis, or small tumor with a mediastinal lymph node metastasis. Stage 3B, mediastinal lymph node metastasis. Stage 3C means the lymph node metastasis in the other side of mediastinum or supraclavicular lymph node metastasis. Now, types of lung resection. Wedge resection, they remove the tumor with the surrounding lung tissues, like a staple out here. And the segmentectomy, remove the tumor with its segments, like this. And this wedge resection and the segmentectomy are called sublobar resection. And the lobectomy means you remove the lobes where the tumor locates, just like this. And the pneumonectomy, you remove the whole lung when the tumor is big, close to the main bronchial trees. There are several different types of thoracic surgery. Traditionally, open thoracotomy, you open the thorax. And video-assisted thoracoscopic surgery, VATS, it's kind of a laparoscopic types of surgery. And more recently, robotic-assisted thoracic surgery. Now, treatment of stages 1 and 2 of non-small cell lung cancer. For small tumor, stage 1A1 and the 1A2, where the tumor size is 2 cm or less without lymph node metastasis. Sublobar resection is preferred. Sublobar resections include wedge resection or segmentectomy. We discussed in previous slide. Indications are tumor size 2 cm or less and peripherally located tumor in the outer 1/3 of the lung parenchyma and pathological negative lymph nodes by frozen section harvested during surgery from hilar, lobar, and the segmental lymph nodes. If any of these lymph nodes are positive, then lobectomy is required. The 5-year survival is quite good. After segmentectomy, 94%, sublobar over 80%. All other stages 1 and 2, lobectomy is preferred. Now, neoadjuvant immunochemotherapy has shown to improve the disease-free survival, which is given before surgery. There is no difference in survival between open thoracotomy and the minimally invasive surgery, like a video-assisted or robotic-assisted thoracotomy. Mediastinal lymph node sampling or systematic lymph node dissection from the levels 4, 7, 10 for right lung, 5, 6, 7 for left lung cancer is required. But complete mediastinal lymph node dissection is controversial in clinical stage 1 and 2 lung cancer. Many randomized studies showed no benefit. About 40% patients recurred after complete surgical resection with a median time of around 1 to 2 years. If surgery is not feasible due to comorbidity or if patients refuse the surgery, then stereotactic body radiotherapy is used without significant difference in survival when compared with the surgery. Stereotactic body radiotherapy is used for tumor less than 5 cm in size, but now many institutions accept the tumor bigger than 5 cm. For this stage 1 and 2 tumor, can you give concurrent chemoradiation therapy? No, the randomized study showed no benefit, just increased the toxicity without improving overall survival. But radiation therapy is indicated for positive surgical margins. Treatment of stage 3 non-small cell lung cancer. For stage 3A, mostly T3N1 disease, where tumor involves the hilar lymph node, not the mediastinal lymph nodes. The surgical resection is preferred if feasible. This is the stage where neoadjuvant immunochemotherapy can step in to shrink the tumor and improve the disease-free survival. If it's not, then concurrent chemoradiation therapy is used. For stage 3B and C, where the lymph nodes, mediastinal lymph nodes are involved, concurrent chemoradiation therapy is the standard of care. Can you give upfront induction chemotherapy to shrink the tumor before you give a radiation or a surgery? No, the randomized study showed no benefit. The chemo regimen for concurrent chemoradiation therapy include cisplatin with etoposide, carboplatin with paclitaxel, cisplatin, pemetrexed, carboplatin, pemetrexed. I'd like to mention that this pemetrexed is only used for the adenocarcinoma only. It doesn't have much efficacy in squamous cell lung cancer. Some studies use the consolidation therapy after concurrent chemoradiation therapy. For example, after cisplatin and the pemetrexed, 4 cycles of pemetrexed consolidation therapy were given. However, after concurrent weekly cisplatin and the docetaxel, consolidation chemotherapy for 3 cycles did not improve survival. For the radiation therapy, IMRT is preferred because of less heart toxicity. The amount of radiation is 60 gray. Previously, higher dose 74 gray was used, but it just increased mortality, so we don't use this high dose anymore. Recently, passively scattered proton beam therapy was promising. It may be better than IMRT. After surgical resection, adjuvant therapy is indicated using chemotherapy, immunotherapy, or targeted therapy. Adjuvant chemotherapy has been used for many years for stage 2 and 3A. For stage 1B disease, it's kind of controversial. Many clinical studies included stage 1B disease in their adjuvant chemotherapy studies. But a new study showed that T2A disease, tumor size up to 4 cm, has no benefit from adjuvant chemotherapy. T2B disease, tumor bigger than 4 cm, chemo lowers the mortality rate for patients with high risk features such as visceral pleural invasion, lymphovascular invasion, high grade, etc. The chemotherapy regimen for adenocarcinoma include cisplatin or carboplatin with the pemetrexed. Pemetrexed has a nephrotoxicity, so should avoid if the GFR is less than 45. And the vitamin B12 and the folic acid is given prior to pemetrexed chemotherapy to lower the hematological toxicity. But some studies show that vitamin B12 injection on the same day of chemotherapy is also okay to prevent the hematological toxicity. This pemetrexed is not used for the squamous cell carcinoma because it has not much efficacy in this squamous cell type. For squamous cell, carboplatin with the docetaxel or paclitaxel or paclitaxel is used. Now, adjuvant immunotherapy. FDA approved the atezolizumab adjuvant immunotherapy about 1.5 years ago when the tumor has negative EGFR or ALK and the positive PD-L1 1% or higher. You give it for 1 year, improve the disease-free survival. Very recently, in January 2023, FDA approved pembrolizumab adjuvant immunotherapy. For this case, you don't need to have positive PD-L1. You can give pembrolizumab regardless of PD-L1 score. It includes the stage 1B tumor 4 cm or above and the stage 2 and the 3A. For 1 year, improve the disease-free survival. Adjuvant targeted therapy is indicated when tumor has EGFR mutation, exon 19 deletion, or exon 21 L858R mutation. For 3 years, it improved the disease-free survival. We discussed adjuvant therapy after surgical resection, but adjuvant immunotherapy is also used after concurrent chemoradiation therapy for stage 3 lung cancer. Durvalumab is used every 2 weeks or every 4 weeks, depending on the dosage, up to 1 year. It increased the progression-free survival and the 5-year survival. But sub-analysis of the study showed the overall survival benefit was seen only for patients with a PD-L1 expression 1% or more. An interesting new development in lung cancer therapy is neoadjuvant immunochemotherapy. A phase 3 randomized studies recently published where neoadjuvant nivolumab and the chemotherapy was given to patients with stage 1B, stage 2 and 3A resectable non-small cell lung cancer having no ALK or EGFR mutations. Just for 3 cycles. Then patients had a surgical resection followed by adjuvant chemo or radiation therapy. The event-free survival was almost 32 months, And interestingly, patients group who received the carboplatin did better than those with a cisplatin. And the benefit was seen regardless of the PD-L1 score. And the pathological complete remission was seen in 24% in those patients who had a neoadjuvant development and the chemotherapy. So the FDA approved this neoadjuvant immunochemotherapy about a year ago. Now, very recently this year, AACR reported neoadjuvant development with the chemotherapy was used as a neoadjuvant immunochemotherapy, just like the nivolumab. And then it showed the improved disease-free survival, and the pathological complete remission was in almost 20%. It has not been approved by FDA, but I'm sure it will be approved sometime this year or even early next year. Another trial include the ipilimumab to nivolumab and the chemotherapy. So it's kind of a triple therapy, and it was better than nivolumab with the chemotherapy. Addition of immunotherapy did not increase toxicity to chemotherapy. However, I'd like to mention that this neoadjuvant immunochemotherapy has not been compared with the standard of care, which is adjuvant immunochemotherapy. So this randomized study is undergoing. For treatment of metastatic disease, targeted therapy or immunotherapy is the mainstay of the treatment. Targeted therapy is the first choice. Very high response rate, 70 to 80%, less toxicity, and the most targeted therapies are effective for even brain metastasis. Targeted therapy is a drug treatment that attacks cancer cells having specific driver mutations with a monoclonal antibody or tyrosine kinase inhibitors. The targeted driver mutations include EGFR mutation, ALK rearrangement, ROS1 rearrangement, MET exon 14 skipping mutation, MET amplification, RET rearrangement, BRAF 600E mutation, NTRK mutation fusion, KRAS G12C mutation, HER2 mutation, and the amplification. So molecular testing to detect one of those driver mutations of cancer cell genome is absolutely necessary. How you detect that? Usually we use the next generation sequencing, but when you need to find the results quickly, you may use the PCR for EGFR or immunohistochemical study or FISH for ALK. FISH test can also detect the RET rearrangement. When the tissue is not enough or not available, then liquid biopsy with the blood can be used. The commercially Guardant 360 CDx is available. But this liquid biopsy has only 60 to 80% sensitivity. So if it's negative, for confirmation, you have to get another tissue by another biopsy for NGS. If patients have a driver mutation positive tumor, do not treat them with immunotherapy first until targeted therapy has been used. If the immunotherapy was used first before targeted therapy, following targeted therapy increased the toxicity like immunopneumonitis, colitis, hepatitis, especially with osimertinib, less with the erlotinib like a Tarceva. Upfront immunotherapy may not be effective even with a high positive PD-L1 tumors when tumors are EGFR or ALK positive. Therefore, for EGFR or ALK positive tumors or other biomarker positive tumors, targeted therapy should be given before immunotherapy. If immunotherapy was given initially for some reason, in my practice, I see some patients who seek second opinion. They already have an immunotherapy before targeted therapy, even they have ALK or EGFR positive. In that case, use targeted therapy at least 3 months after immunotherapy was stopped. If urgent therapy is needed, then chemotherapy is given in between. Also, avoid combination of targeted therapy and immunotherapy because it increases toxicity and it provides less efficacy. The contraindication to immunotherapy include connective tissue disease and rheumatological disease, interstitial lung disease. I also like to emphasize that glucocorticoids, immunosuppressant glucocorticoids, may weaken the efficacy of immunotherapy. So try to avoid or use a minimum dose, not more than prednisone 10 milligram or dexamethasone 2 milligrams a day. Now, targeted therapy for EGFR mutations and the ALK rearrangement. EGFR mutations include exon 19 deletions or exon 21 L858R mutations. It's detected in about 15% of patients, but it's much prevalent in Asian women who are not smokers, seen in 60% of them. EGFR tyrosine kinase inhibitors have a 3-generation drugs. First generation, erlotinib, Tarceva, or Iressa. Second generation, afatinib, Gilotrip. Third generation, the most popular, osimertinib, Tagrisso. The osimertinib is an irreversible EGFR tyrosine kinase inhibitor. Has a very good overall survival compared to the first generation drugs. 80% response rate. Overall survival over 3 years. Has some side effect with the QT prolongation and the decreased left ventricular function. It also effective for brain metastasis. When the patients develop resistance to first and second generation drugs with T790M mutation, this osimertinib is effective. The second generation afatinib, Gilotrip, is indicated for non-resistant other EGFR mutations like S768I, L861Q, and the G719X. There is no cross-reactivity between Tagrisso or osimertinib, so you can switch to other. Side effect is sun sensitivity. Avoid the direct sunlight. The first generation we don't use that much anymore. ALK rearrangements are seen in 4% of adenocarcinoma, more in non-smoker young patients. It can be tested with the immunohistochemical study, FISH, and the NGS. I mean ALK rearrangement, not the ALK gene amplification. Gene amplification, ALK gene amplification alone without ALK rearrangement may not be sensitive to ALK inhibitors. ALK inhibitors include alectinib. We used to use crizotinib, but we found this alectinib is much more effective. Newer drugs are brigatinib and lorlatinib, which is third generation. It can be used as a first line or second line treatment. Response rate is about 80%. This alectinib, brigatinib, and the lorlatinib are effective for brain metastasis as well. If the CNA brain metastasis become resistant to alectinib, then you can increase the dose or switch to lorlatinib. Now, targeted therapy for less common driver mutations. ROS1 rearrangement is in 1 to 2% of adenocarcinoma, mostly non-smoker and the young patients. Inhibitors include entrectinib or crizotinib. If progressed over crizotinib, lorlatinib or cabozantinib can be used. For MET exon 14 skipping mutations, which is seen in 3% of adenocarcinoma and 20% of sarcomatoid non-small cell lung cancer, Camotinib or tepotinib is used. For MET amplification, which is seen in up to 20% of EGFR mutated tumors that are acquired resistant to EGFR inhibitors, camotinib or crizotinib are inhibitors. For RET rearrangement, frequently seen in medullary thyroid cancer, but 1 to 2% of adenocarcinoma in young never smokers, selpercatinib and the pralsetinib are inhibitors. For BRAF mutations seen in 1 to 3% of adenocarcinoma, mostly smokers, detected by PCR or NGS, BRAF inhibitor dabrafenib, bemurafenib are effective but short-lived due to resistance. So addition of MEK inhibitor trametinib to BRAF inhibitor dabrafenib improved the overall response rate to 70% and the disease-free survival. Important side effect is fever. This combination of dabrafenib and trametinib is not effective for BRAF non-V600E mutations. And NTRK fusions inhibitors are entrectinib and the larotrectinib. Very good overall response rate. Once they respond, the duration of response lasts often years. KRAS G12C mutations are seen in 10% of adenocarcinoma, mostly smokers, and the inhibitors include sotorasib and adagrasib. Adagrasib are very recently approved. Overall survival rate about 1 year. HER2 mutation is seen in 1 to 3% of adenocarcinoma, mostly women, never smokers. Famtrabtuzumab in HER2 provides response rate 55% and the survival 1.5 years. It's important to know that HER2 amplification, like a breast cancer or HER2 positivity, has no association with the HER2 mutation, but 25% of HER2 amplification positive without mutation respond to Enhertu, that famtrabtuzumab. For narrow G1 fusions, the afatinib may be used. Now, immunotherapy. Immunotherapy with the immune checkpoint inhibitors is used when driver mutations are absent or unknown. Immunohistochemical study for PD-L1 expression should be done in all non-small cell lung cancer. There are 2 tests for PD-L1. Score reported as a 0 to 100. For the lung cancer, we use the tumor proportion score. It is calculated by PD-L1 plus tumors divided by PD-L1 positive and the PD-L1 negative tumor cells times 100. For other cancer type, CPS, combined positive scores are used. The formulation formulates PD-L1 positive cells, including tumor cells, lymphocytes, and the macrophage, divided by PD-L1 positive and PD-L1 negative tumor cells times 100. So the score can be even over 100, very rare. It's used for other type of cancer, head and neck, esophageal, gastric, cervical, and the triple negative breast cancers. How long does it take for the immunotherapy to show effectiveness? Time to respond is usually longer for immunotherapy than chemotherapy. Most clinical trials show that time to response following pembrolizumab therapy was 2 to 3 months. If used with the chemotherapy, it works faster, 1.4 months. Pseudoprogression is seen about 10 to 20% of patients. In the beginning, after the immunotherapy, tumors swell because of inflammatory changes. But patients usually feel better, not feeling sick. If you really want to know, you can check the circulating tumor DNase, which is less, and the PET scan show the less avidity. If you really want to know, you have to do the biopsy, which showed no cancer cells. Hyperprogression is defined by tumor growth exceeding 50% per month. It's seen in 14% of patients treated immunotherapy. In those cases, you immediately have to switch to chemotherapy. Glucocorticoids may weaken the efficacy of immunotherapy. The daily dose more than 10 milligrams prednisone, which is 2 milligrams dexamethasone, causes poor outcome with the immunotherapy, published in 2018, especially when used with a higher dose of steroid. So prudent use of steroid at the time of initiating immunotherapy is highly recommended. In other words, if possible, do not use the corticosteroids. Let's discuss immunotherapy for metastatic non-small cell lung cancer. When PD-L1 expression is 50% or higher, immunotherapy alone is sufficient with pembrolizumab, atezolizumab, or cemiplimab. But for high tumor burden or rapidly progressive disease, combined immunotherapy and the chemotherapy is better because it works quicker. For PD-L1 expression less than 50%, combined immunotherapy and the chemotherapy for 4 to 6 cycles, followed by immunotherapy maintenance. For immunotherapy, we can use pembrolizumab, atezolizumab, or cemiplimab, or a combination of tremelimumab and the durvalumab, plus chemotherapy, either carboplatin with pemetrexed for adenocarcinoma, or carboplatin with the paclitaxel or nab-paclitaxel for all other non-small cell lung cancer, including squamous cell carcinoma. Overall survival of cemiplimab with the chemotherapy was 22%. Without immunotherapy, only 13%. When pembrolizumab was used with the chemotherapy, the overall survival is the same, 22 months. Tremelimumab and the durvalumab and the chemotherapy, the overall survival was 13.3 months. Pembrolizumab monotherapy was recently approved by FDA for PD-L1 score more than 1%. Overall survival 17 months. Dual immunotherapy nivolumab and ipilimumab also approved for PD-L1 score more than 1%. Similar overall survival. When the PD-L1 expression is 0, then we can use chemotherapy and the immunotherapy combination as above, or chemotherapy alone, or chemotherapy with the bevacizumab. The bevacizumab improved overall survival when used with the chemotherapy, or dual immunotherapy, nivolumab and ipilimumab, with 2 cycles of platinum-based chemotherapy. The overall survival 14 months is approved by FDA. Frail patients, atezolizumab monotherapy was better than chemotherapy, regardless of PD-L1 score. Very recent publication. For maintenance, for adenocarcinoma, pemetrexed with pembrolizumab. For squamous carcinoma, either docetaxel or gemcitabine with pembrolizumab. Bevacizumab is not beneficial as a maintenance therapy. Now let's study small cell lung cancer. There are 2 staging systems, VA lung study group and the TNM systems. The VA study group system is much more popular, which has 2 stages, limited stage and extensive stage. In limited stage, tumor and the metastatic lymph nodes, if any, are confined to the same side hemithorax, so it is included in a single radiotherapy port. In TNM stages, it belongs to stage 1, 2, 3A, and B. In extensive stage tumors beyond the limited stage, including distant metastasis, malignant pleural and the pericardial effusion, contralateral supraclavicular or hilar lymph node metastasis. For treatment of limited stage, surgical resection followed by adjuvant chemotherapy is used for a small solid tumor, T12N0 stage 1 disease. When compared with the concurrent chemoradiation therapy in a retrospective study, surgical resection followed by adjuvant chemotherapy yield higher survival over 3 years versus less than 2 years. If the lymph node metastasis is found after the surgery, would you give radiation therapy? Not necessarily. Only for mediastinal lymph node metastasis. For N0 or hilar metastasis, radiation therapy is not necessary. Studies showed no benefit. For stage 2, stage 3A and the stage 3B, surgery is not a choice. Concurrent chemoradiation therapy is the standard of care, using cisplatin or carboplatin with etoposide. For radiation, all gross disease and all nodal regions are radiated. When do you start the radiation? Earlier the better. Radiation starts concurrently with the first or second cycle of chemotherapy, which is early radiation therapy. This early radiation therapy is better than late radiation therapy in overall survival rate. When patients achieve complete remission or good partial remission after concurrent chemoradiation therapy, then prophylactic cranial irradiation is given as it improved the overall survival, except stage 1 disease. For stage 1 disease, prophylactic cranial radiation may not improve the survival, so it's controversial, needs to be individualized. How much radiation to the brain? The lesser the better. 25 gauge in 10 fractions causes less neurotoxicity than higher dose, 36 gauge. When you give whole brain radiation, hippocampus saving technique is better. It can reduce the cognitive dysfunction side effect. For treatment of extensive stage, combination of immunotherapy and chemotherapy improve the survival when compared with the chemotherapy alone. For immunotherapy, atezolizumab or durvalumab is used with carboplatin and etoposide. Pembrolizumab with the chemotherapy did not improve overall survival, so pembrolizumab has no role in induction therapy for extensive stage small cell lung cancer. When patients have a residual thoracic disease after induction immunochemotherapy, then thoracic radiation therapy improves survival. But when patient had a complete response, no residual disease, then radiation therapy is not necessary. It doesn't improve the survival. Prophylactic cranial irradiation for extensive stage is controversial. The results are conflicting, so it should be individualized. When patients did not have prophylactic cranial radiation, surveillance with MRI brain is necessary. When the patients have a relapsed or metastatic disease, the first thing to look for is the disease-free interval, which is the interval between the chemotherapy and the relapse. If the interval is over 6 months, then disease is considered as sensitive to initial chemotherapy like a carboplatin. Then the initial chemotherapy is tried again with or without immunotherapy. But if the interval is shorter than 6 months, then second-line therapy with lurbinectedin or topotecan is used. For brain metastasis, radiation to the brain is initiated, and the topotecan can be tried. Topotecan has some efficacy in brain metastasis, but not the lurbinectedin. Lurbinectedin was not tested in brain metastasis in clinical trials. Recently, a landmark study was published. We expect the good results with the lurbinectedin when combined with the doxorubicin, but when compared with the topotecan, it did not improve overall survival. If it progressed over lurbinectedin or topotecan, and the patients never had any immunotherapy as in induction therapy, then pembrolizumab may be tried. Otherwise, single agent chemotherapy like a paclitaxel or taxotere is the third-line treatment. Interestingly, some studies reported induction chemotherapy is effective for brain metastasis, like a carboplatin with the irinotecan. With a response rate of 65%, encouraged with these results, a phase 2 study was initiated using atezolizumab with a chemotherapy for patients with asymptomatic brain metastasis. The results is expected to be published later this year. Whole brain radiation therapy is the standard of care for brain metastasis in small cell lung cancer, but more institutions are using stereotactic radiotherapy without whole brain radiation, because whole brain radiation may increase the cognitive toxicity. Now, let's review the published data of prognosis. Non-small cell lung cancer first. The 5-year survival of stage 1 disease is 80 to 90%. Stage 2 disease about 60-65%. Stage 3A 41%. Stage 2B 24%. Stage 3C 12%. Stage 4 8%. Small cell lung cancers 5-year survival of limited stage about 20%. Extensive stage is less than 10%. But look at the data. When these data are extracted from the patients who was treated from 2013 through 2019, before we widely use targeted therapy and the immunotherapy, then what is the real prognosis in 2023? I must tell you, it should be much better than this data. This is the Abbott Northwestern Hospital and the Allina Health Cancer Institute where I'm working now. I like to read this Bible verse from Isaiah, hoping that all cancer patients have courage and hope during their fight against cancer. So do not fear, for I am with you. Do not be dismayed, for I am your God. I will strengthen you and help you. I will uphold you with my righteous right hand. Thank you for watching.